they want the best for their patients, which is the right thing. And they also get paid better for better outcomes of their patients. And I think one of the things they did was, like, during a heat wave in Philadelphia, they went and bought air conditioners for their patients. Right? Like, I mean, think about that for a minute. Like, this is a doctor trained in internal medicine, has decided that we have a heat wave coming. Potentially our patients are going to get hospitalized. If they get hospitalized, one, that's bad for the patients. It's bad for us. We love our patients. We don't want that to happen.
Welcome to the Message Engineer Show. I am Maureen Shaffer, the host, and today we have Dr. J.B. Muñoz, MD. He is currently active in medical device development and is a patent holder in medical AI. Dr. Muñoz has worked as a medical director, combat physician, and surgical intensivist at the U.S. Department of Defense, or DoD. He was awarded a Congressional Fulbright Fellowship, which he applied to infectious disease research in South America. And Dr. Muñoz graduated from Duke University, my alma mater, School of Medicine, and did his general surgery residency at Harvard. So welcome to the Message Engineer Show.
Thank you, Maureen. Very excited.
Excited to have you. I just wanted to quickly shout out MedTechVets for introducing us. And you can check out MedTechVets.org to learn more about them.
Yes, outstanding organization. All the kudos to MedTechVets. Yes, they're a wonderful organization. I think everybody should look them up, reach out to them. Wonderful, wonderful service for our vets and active duty service members.
And a great opportunity for medtech companies to hire some really amazing people with incredible experience.
Yes, absolutely.
All right. So we start with define the word warm up. So a couple of words. I'm really curious because everyone's talking about it. And you've had a chance to work with it on the medical side. So medical AI.
Oh, wow. Yeah. Big topic, huge topic. So define the word. So I think when I think of medical AI, I essentially think of large language models that can supplant and assist physicians in making clinical decisions. I'm sure medical AI is probably a larger umbrella term. It would encompass all of medicine. But for me personally, being a clinician, I think of it more as large language models that will help digest encyclopedic amounts of information from the internet, and then give those to us physicians in digestible insights to help us make better clinical decisions. That's how I think of them.
That's great. Everyone's talking about AI and it means something different to everyone. So it's very helpful to have kind of your view on that, your point of view on that. A couple ones which you should probably expect. Message. Yeah. So I guess when I think, I'm reminded, so I did an internship when I was younger, when I was in college. I did an internship with a Surgeon General, and he one of the lessons he beat into my head was message versus meta message. And ultimately, so, as being a very early lesson and something that just kind of stuck with me, when I think of message or meta message, I ultimately think of, what is the thought virus or mental virus that is implanted in your brain when somebody has achieved your attention. You've devoted your attention to that. They deliver an item, a fragment of information. What do you walk away with? I consider that to be the message. That is a great way to look at it. It's one of the things that in, kind of classical traditional advertising, they measure, right? Is what do you remember?
Right. And of course, to his point, when I was interning with the Surgeon General, he said, you have to be careful because you're going to deliver a message, but your body language, your tone, who you are, your background, all those messages carry a meta message with them. And so always be cognizant of your meta message.
So by meta message, did he mean, and do you mean kind of all the nonverbal cues, or is it more different than that?
And I think anything beyond what you maybe didn't intend, right? So you may have a
Mhm.
talking point or a message that you want to deliver, but then, incorporated in this kind of larger global sense of all the things that surround you, the deliverer of the message, what you did or what platform you use to get the person's attention, all of that, there's this kind of metaverse around your message that is also delivered with your message. And so you have to be cognizant of that at all times as well. And that, yes, that includes, you as the messenger. It includes your tone, nonverbal cues, et cetera. I mean, all of the above.
Yeah, as well as yeah, I love the idea of including the platform on which it's delivered, right? You can imagine if it's delivered via, I know it's a Surgeon General, let's say the American Medical Association, right? Or
Right.
WHO, it carries a certain gravitas to it that if you were to
Absolutely.
deliver it via, I don't know, some local news station in some small town in the United States, may not carry, right, the same amount of, may be important, may not carry
Yeah.
the same amount of weight.
So what's the and this I'm dating myself here, right? I mean, so I did that internship when I was in college, and at the time, the Surgeon General at the time was David Satcher, and he speaking about the message upon which you deliver things, right? So he would tell me, I go around all the time and I tell people live a healthier lifestyle. I tell them, eat more fruits and vegetables or get more exercise. And he's like, it's one thing to tell somebody that and then shake their hand. That's one way to deliver the message. I could also write it on a sticky note and give it to them. But so what he did was he had a prescription pad printed out and he put down on there all of the major kind of health advice that he wanted to deliver to people, and he would have little check boxes on them. And so when he would meet people, he would get their name, he'd write it on the prescription pad, and then he would just check off what health advice he wanted to give them, and he would hand it to them. And of course, it'd be signed already, Surgeon General David Satcher, and that's how he would deliver his messages. It was clever and kind of for the late '90s, it was. It had a lot of traction back then. I don't know anymore now that little paper scripts have any traction. Most probably millennials and Gen Zs don't know what a prescription pad is, but back then it was a useful way to spread the message.
Well, I think that's fascinating because there was, I mean, whether it's a prescription pad or it's another kind of medium, right? It's that the weight that people used to take, if someone gave you a prescription, you take it seriously. If they're like, hey, you may want to consider taking some vitamins, that's less of if they wrote it down with the, so many milligrams a day or a week, or felt a little more serious. So
for sure, and to that extent, it's kind of funny to think about how medicine has transitioned. So when I first kind of had my first initial decisions to think about going into medicine, well, I'd been a paramedic before I even went into medicine, but going through the paramedic courses and whatnot, we learned, I don't remember why, we had to just learn, we had to learn how to read prescriptions. And so we had to go through this whole medical language and medical terminology course, and then also learn how to read prescriptions. There's a whole scribe kind of nomenclature for writing prescriptions, and I had to learn this. And I remember thinking when I went to medical school how excited I was. I mean, that's the weapon to yield, right? If you're going to become a soldier, you learn how to shoot a weapon, and that's kind of an exciting part about becoming a soldier, is becoming really tactically proficient in weapons and firearms, etc. And you become a doctor, you learn how to wield a scalpel, but then you also learn how to wield a pen and a prescription pad. And that's how I'd always envisioned it. And then only to find out that, like, as I graduate medical school, all prescriptions are now written on computers, right? So there's no need. I still remember how to write prescriptions in that old prescription nomenclature, but it's completely useless now. I don't, it's completely archaic and obsolete. But one of my main disappointments after getting out of med school.
Sorry to hear that.
Yeah. Every now and then I spend my evenings just writing old prescriptions in the old prescription nomenclature just to pass time.
Oh, that's so funny. It is funny to think back at what used to be important skills and what have gone completely obsolete. And I think that it's out, right? I wonder, looking forward, right? Everything is in NEH. It rolls up in some way, shape, or form at the end of the day to an electronic history record, right?
For sure.
The most data, not all, but a lot. And I wonder kind of AI, we see AI as kind of the next thing coming down the pike. Do you see any other, there's a lot of shifting going on in the industry, right? Primary cares, disaggregating a bit and shifting. A lot of these hospitals and even surgeons and physicians are employees of these very large healthcare systems that include a lot of different facilities. I mean, what do you have a sense for kind of what comes if there's AI? And then what are some of the exciting things going on that you think are really heading us towards the future in?
Yeah, I mean, when you ask that question, that the first things that the first thing that's going to mind, I have a lot of ideas about like the kind of the future of healthcare and what's going to happen to healthcare in kind of this global sense. But like as far as like the kind of there's also this healthcare technology sphere where there's just like some really sexy stuff coming down. AR, VR, really interesting. I don't know how much traction or how much throughput or how much weight it will ever gain in the medical sector. I mean, obviously there's some challenges that Meta or Facebook is currently facing with the whole VR revolution or the transition to VR. But in medicine, there's some really, in my opinion, the neat stuff that's coming out is kind of the interface of VR and AR and robotics in medicine, particularly in surgery. That's the really neat kind of sexy stuff. Unfortunately, that I think is such a small part of healthcare as a whole that that's probably more of a niche and just more of a kind of an interest of mine. But as far as healthcare as a whole, I think I work very closely with a company called Pearl. I've partnered with them recently, and they are kind of more on the global management of patients and assisting physicians in this value-based care. Kind of transitioning more from fee for service and kind of a transactional relationship between doctors and patients to this kind of more holistic, global, total population control and population health management movement. And so the first, and I don't know if this is the right answer, but it's the first answer that comes to mind when you say like, what do I kind of see happening, particularly with AI? I mean, all that I think will fit into this larger picture of the global continuum of care. And I think health systems are going to start taking responsibility for patients over a more global trajectory of their lifetimes or over larger parts of their lives. And to kind of give you a scenario that will illustrate this, so value-based care is this kind of new model that came out of CMMI, and it essentially is trying to promulgate a system in which doctors will take more initiative and take more responsibility and take more control over the outcomes of their patients in the healthcare system, so that you'll get paid based on how well your patients do. Well, if you're going to do something like that, you really have to have a more holistic picture of your patients, right? Because you can't just see somebody for 20 minutes a month or 30 minutes a week even, and then be expected to be responsible for the entire trajectory and the entire continuum of care for that patient, right? So in order to do that, in order to be responsible for the entirety of a patient's health and welfare, and to be, like Hippocrates said, the guardian of their health and welfare, you need a lot more insight to what your patients are doing. You need to know what they're eating, when and where they're exercising, what do they spend most of their time doing, what dangers, environmental and otherwise, are they exposed to in their daily lives. And so as I look at some of the both the tech, the software, and just the behaviors, attitudes of these healthcare systems, there's a greater amount of focus on getting information on patients throughout covering the entire spectrum of their daily lives, not just what you get from their blood pressure, pulse ox, heart monitor in a 30-minute visit. So I mentioned Pearl. One of the real interesting things about Pearl Health is that they've got a to me just this groundbreaking revolution, just sector revolutionizing software platform that allows them to see all the touch points that a patient will have with the healthcare system. It allows them to see when your patient gets a med refilled, when they get discharged from a hospital, when they go to urgent care, when they've been seen by you, when they're due for their annual well visit, when they've had a routine recommended procedure, so like a colonoscopy or a breast exam. You can see all of this stuff regardless of kind of where they go, as long as it's reported to CMS, it gets logged into the software system, and then the doctor can see all of that. So now you're not just restricted in seeing your patients, you're not just restricted to what they tell you or just what shows up in the EMR in your office. You now have a view of what interactions they're having with the health system as a whole. And so I think that's in overall, to answer your question, I think that's where healthcare is going. And then the question is, well, how will AI integrate with that? And ultimately, I just think AI in the early stages will just be used to kind of collate that data and into nice digestible data insights for the physician.
It's interesting because you said because I thought, how are they, right? We know about all these big health systems. How do you pick up all that data? But CMS, right? So presumably Medicare or Medicaid patients at this point in time.
Yeah, predominantly Medicare at this time, but
Mm-hmm.
Medicaid will fit in. So yeah, it's the CMS data. Yeah.
Yeah. So starting with kind of the older patients who tend to have, from what some of the data I've read, an increasing number of chronic diseases, right? Most of those are preventable in some way,
Yep.
shape, or form.
For sure. For sure.
I'm curious, and I mean, this gets to kind of marketing and med tech and development of things. I heard something the other day that someone said something to the effect of, the problem is that we get folks as adults at 18 or 21, but the bulk of what will affect their future health has already occurred. Like those things that are going to affect how they eat or how they exercise, or childhood trauma, things like this, have already happened. So are we kind of, it's always a question in healthcare, right? You have to start somewhere and get moving.
Very true.
So
Yeah.
what Pearl's doing sounds really exciting. I always wonder, we tend to focus on end of life, right? Because there's a lot of dollars spent there.
Right.
Is that?
Yeah. Yeah,
What
no.
do you think?
So I think I'm reminded of this when I was in college. I did this program. I went to USC in Southern California, but I did this program up at Stanford. It was like a summer healthcare for people who were interested in healthcare. And
Mm-hmm.
I remember they assign you with a partner to do research with. They assign you with a faculty member, and you're supposed to just do this like summer research project or whatever. And I was working on at the time like obesity, metabolic syndrome, stuff like that. And I remember coming across in kind of like my pre-research, coming across an article, and I would love to be able to cite it. I've forgotten it, but who wrote it or what journal it came out in. But ultimately, what I remember it suggesting was that, particularly with metabolic syndrome, your metabolic syndrome is your baseline metabolic state is essentially defined in your teen years. And one of the things they pointed out was like the number of fat cells that you're going to have for your lifetime is essentially defined in your preteen, adolescent, and then teen years. And then the fat cells from there on will just grow or shrink depending on how much exercise you do or how you eat, diet, that sort of thing. But the number of those cells is kind of defined. And so if you've already been set up at that stage, if you're an obese child, in your metabolic state is somewhat set at that point, it would stand to reason that the difficulties that you would have to then kind of change that, alter that, and not to say that people can't, certainly they can, but maybe the challenge to do so becomes more difficult for people who grow up, sedentary, who go through those kind of formative years, sedentary with a bad diet and kind of develop those early stages of metabolic syndrome. So absolutely to your point, if you get a patient at 18, 20, I mean, if you get a patient at 16, in some cases, some of the damage has already been done. And then you're kind of fighting, you're pushing that rock up the hill for the rest of their life, trying to reverse some of those stages. And so, yeah, I mean, as a clinician, it's hard to change or address things that you can't measure. And so you want to have some sort of visibility of those factors. And of course, EHRs, and as they continue to proliferate and they become more expansive and more systemic, really, and data starts to flow through those, you'll be able to gain visibility on those factors. But that's key to having a larger impact on people's overall trajectory of health over their lifespan.
Yeah. Yeah, absolutely. So, and this idea of, population health and value-based care, in the past, people attempted some of these things, right? They worked for a specific population for a small period of time, but they weren't largely scalable or kind of extensible across. I mean, we all want value, right? We all want value-based healthcare, right? We all want to be well and get away from sick care, right? And focus on well care. Are these the right things? Are there other things that you see on the horizon that also look interesting or are necessary kind of pieces of the puzzle to solve?
A couple items on that, so here's what worries me about the whole value. Like, you're right. So, well, let's just go back to this. So CMS and, we'll just call our government healthcare programs they've been one big experiment since their originations, right? And they continue, particularly with the CMMI, the Center for Medicare and Medicaid Innovation, which I think has been around since like the mid 2010, 2011, something like that, has really been an investment in the evolution of our government healthcare system, which when I say government healthcare system, I'm leaving out DHA. I'm just kind of more focusing on Medicare, Medicaid. But so they've basically been formed and they're funded to try to evolve the Medicare and Medicaid system to a more efficient, value-based system, for lack of a better word, with better outcomes. And so certainly there's innovation taking place. Certainly there's investment in trying to find solutions. And and as you alluded to, like, that just leads to constant iterations, constant trial and error to try to find the best thing. And nothing, you're right, nothing has really taken off. I think there was a review in like 2020 of the I think it was New England Journal of Medicine. They kind of looked at CMMI's programs from 2010 to 2021, so about 10 or 11 years of CMMI data. And they kind of said, okay, well, listen, costs haven't necessarily gotten better, but they haven't gotten much worse. The outcomes of the patients haven't gotten much better, but they haven't gotten worse. So basically, it sounds like what CMMI has essentially been able to do is just kind of plateau the status quo in Medicare and Medicaid patients, right? They haven't made anything worse, haven't made better. It hasn't gotten more expensive, hasn't really solved the problem of cost. So if anything, it's just kind of wrangled it in. So yeah, so I think we're still looking for solutions. To me, there's two main problems. And one of them is what we talked about, is like, in order to really be responsible for the outcome of your patients, you kind of have to have 360-degree visibility of your patients, because you need to know what they're doing, what they're engaged in. And then you have to have the tools to address whatever those needs are. I mean, I remember hearing recently on a podcast or something about Chen Med. I think they're based out of Philadelphia or Pennsylvania. They're like this accountable care organization. And, in order to ensure that they get, I don't want to say they make money off of, but, they're incentivized towards the better outcome of their patients, both financially and psychologically and, spiritually, because I think they're a religious-based healthcare group. They want the best for their patients, which is the right thing. And they also get paid better for better outcomes of their patients. And I think one of the things they did was, like, during a heat wave in Philadelphia, they went and bought air conditioners for their patients. Right? Like, I mean, think about that for a minute. Like, this is a doctor trained in internal medicine, has decided that we have a heat wave coming. Potentially our patients are going to get hospitalized. If they get hospitalized, one, that's bad for the patients. It's bad for us. We love our patients. We don't want that to happen. Two, we that threatens our overall shared savings on those patients. So we're going to buy air conditioners to make sure that they don't, we talk about I've never heard of a doctor writing a prescription for an air conditioner, but in this case, there you go. Right. So to get back to the point, so taking care of patients, you need to have global 360-degree visibility on your patients, and they're all the way up to what kind of their home living environmental situation is. And then you have to have the tools, right? I think it's fairly standard to reason that if there's a heat wave, an air conditioning could potentially protect you from, the morbidity of a heat stroke or heat exhaustion and ended up in the hospital. Where it gets tricky for me, and what I struggle with kind of both in clinical practice as well as just my interactions with the healthcare system on my own, is what tools are we giving doctors to help them take care of their patients? And, there's been a lot of controversy recently on, particularly surrounding opioids and different medications and the pharmaco healthcare industrial complex and, the hijacking of evidence-based medicine by corporate entities who stand to benefit by, some might say, influencing, some might say manipulating doctors' practices. That's what I worry about. Like, we have this reliance as doctors. We think the best thing for our patients, the best outcome for our patients, is to follow evidence-based medicine. And yet, if you had asked me 10 years ago, I would have gladly told you, based off of, the published works that I was being handed and the interactions and conversations I had at conferences, that, oh yes, any patient who undergoes an appendectomy needs 90 days of opiates after their appendectomy, right? And we now know that, I think it was last year or the year before was the first time since the 1950s or the 1940s that the average lifespan of an American went down. And part of that, of course, part of that was attributed to COVID, but the other part was
Mhm.
opiate overdoses. And so here we are. I even have a quote here that I say, so, value-based care is an effort to reward physicians for helping patients improve their health, reduce effects and incidence of chronic disease, and live healthier lives in an evidence-based way. Evidence-based way. We doctors, we rely on the evidence to treat our patients. And if we're not getting correct evidence from,
Mhm.
our academia, from, these corporations that circulate healthcare information, if we're not getting the right information, we could potentially be harming our patients. And I'm reminded of a quote I heard recently. It's something like, in the last 30 years, something up to, and I might be butchering the numbers here, something up to like 70% of all pharmaceuticals that have been developed in the last 30 years have actually proven to be more harmful than helpful. Like,
Wow.
don't quote me on those numbers, but like, it was something that I
Right.
heard recently. It's shocking.
It
So
wasn't 1%. It
yeah,
was a
right.
very large number.
It was directionally, I think those numbers are right. I think it was from Asim Malhotra, who's I think he's a cardiologist from the UK. I think it was his quote on a recent podcast. But yeah, I mean, if as a doctor, if you're going to be responsible for the overall health and welfare of your patients and their outcomes in the way that these value-based care models are suggesting, you need to have tools to be able to do that. And I worry that that a large result of the rising costs in healthcare and the poor outcomes is that we're giving people expensive things that aren't actually helping them.
So a lot to unpack in there.
Yeah, sorry, you got me
Really
going, Maureen.
cool.
You got me going.
That's good. That's good. So 360-degree view tools. There's a lot, but 360-degree view tools, and isn't it evidence-based medicine, right?
Yeah,
We all rely on, so maybe I'll start in reverse. When you say evidence-based medicine, obviously I think, National Library of Medicine, PubMed, peer-reviewed journals, and then to simplify the mass amount of information publications, the clinical guidelines that are formulated by different committees, sometimes within an organization like the American College of Cardiology or the American Heart Association, or collaboratively, the AHA, the ACC, and the Heart Rhythm Society get together and write something
sure.
on AFib, for example.
Right.
And they do rate. I always appreciated the fact that they rated the level of evidence, right? So that you have a sense of how strong the evidence is in support of some particular thing they're putting forth.
Right.
It's interesting because there is, at least in my experience, we've never tried to influence the guidelines. We have been aware who writes them, right? We've tried to work with those people on larger scale. Once we had things proven in smaller set studies, we've tried to involve some of those people in some of the larger trials so that we were more from are we measuring the right endpoints, right? Are we doing the right tests? Are we measuring the right endpoints? Are we, with obviously the hope of eventually getting, having sufficient evidence to be considered to be in the guidelines? Are you speaking when you're talking about questioning the evidence and the evidence-based guidelines? Are you talking about that, or are you talking about something else?
No, I'm talking about that. And I don't want to, Maureen, I thought this was going to be a happy podcast, and I think we were going to talk about nice, fluffy things, and maybe look at some cat videos. I don't mean to be
no cats. I am
dog
super
person, right?
super allergic to cats.
Right. So I don't want to be a purveyor of doom and gloom here, but let's talk about this for a second, just to make sure that we're being faithful to the science and what we know. So a couple of old terms and sayings I'm going to throw out to you, and I think this one has been bandied about quite a bit. So, and we all heard this when all of us doctors graduated med school. I think we've heard this in some way, shape, or form since graduating med school. I think it was a former dean of Harvard Medical School said to a graduating class, welcome to the science of medicine. 50% of what we taught you here is absolutely false. And the worst part about that is we don't know what 50%, right? So keep that in mind. And then take that onto, there's a Dr. Ioannidis, or I'm butchering the last time, Ioannidis out of Stanford, who published a study in the early 2000s where he talked about how journal articles, which is evidence-based medicine. Evidence-based medicine is basically what can we derive from the journals and the publications, the National Library of Science, et cetera, of the collections of those articles published. What kind of data insights can we derive from them? And he's a very brilliant data scientist, a physician, and he looked at it over a certain number of years, and he said up to half of medical literature published is wrong, maybe more. And to a great degree, that which is wrong, it's more likely to be wrong if it is influenced by any type of financial investment or windfall from a corporation.
Sure.
So first of all, even before corporate influence in medicine, we were already saying, listen, 50% of what we teach you in med school is probably wrong, and we don't know what 50%. And then in the era of evidence-based medicine, we have doctors like Dr. Ioannidis who were warning us that even potentially half or more than half of what's published, the evidence, the science of medicine, potentially over half of that is wrong and could be harmful. So we have to be very careful with how we're utilizing the science, the evidence, where it's coming from. And I think it gives us a little bit of a peek into the dangers of AI. How so? Like this. So you mentioned the guidelines. The guidelines are nothing more than digestible, easily delivered insights that have been collated and collected by a small group of physicians, essentially, who are reading language. They go on the internet, they go through the libraries, they flip through the encyclopedias and through the journal articles. They collate all that information, they make it into digestible pieces of data insight. That's essentially AI, just a human form of AI. We don't call it AI, right? Because it's not artificial. It's actually humans doing this. That's what they're doing. But the insights we get, the guidelines, are based off of evidence. The evidence comes from journals. The journals are published, produced, funded in many cases, by corporations,
by advertising,
pharma, right, advertising, etc.
Largely from corporations.
They can be influenced. Some of the leading scientists who publish the most works on statins, for example, been shown that they are influenced in some ways by the medical establishment. And I mean, the biggest indictment of this, bar none. I mean, there's probably several documentaries and books written about now, is the opiate crisis, right? Like, the Purdue Pharma, they basically found one article in one journal from the 1970s that said opiates aren't addictive. They took that one journal, it wasn't even a journal article. I think it was like a statement piece or a case study or something like that. And they basically, and they basically just started floating that around in their sales pitches and said, listen, opiates aren't addictive. Oh, and if your patients are experiencing what appear to be addiction symptoms, that's actually pseudo addiction. It means that they need higher doses. And we kind of bought a hook, line, and sinker. So that's the danger, right? So, and that's the danger with AI. If AI is not, this is like computer programming 101, right? Like input and output. If you don't have good input, you're going to have bad output. So the information that goes into these AI models and the information that go into these guidelines, has to be trustworthy, verifiable, and reliable, high fidelity information.
Yeah, you make a great point, because there's a lot of, I know when we read articles, or when I've had conversations in the past with physicians about them, they're always more cautious about, well, the early data, is trending towards, right? They stay away from definitive statements until you have the 3,000 patient multi-center randomized prospective trial, and then it becomes a bit more definitive, right?
Yeah.
But all these smaller studies are stepping stones, and there are, somebody somewhere probably came up with an algorithm for this already. But you look at the right? You look at the people who were a part of the study. You look to see if there's any funding given. You look to see which institution, which journal, how many patients, the N, the p-values, that, right? There are indicators that give us some sense of directionality for, I hesitate to say trustworthiness, but
I mean, that's the whole
in that regard.
Yeah.
But how do you so I suppose if humans can do it, AI could do it, but it depends what they're taught and how they're taught it. And if they can discern, you know, any of these guidelines will always say, we looked at, I'm just going to use even numbers, 1,000, we looked at 1,000 articles that fell under the following keyword search. So many got tossed for this level, you know, not enough, and what the number of people weren't high enough. They got tossed for this, they got tossed for the other thing, right? And call it down. I suppose if they have a process, the AI could have a process, but
Yeah, I mean, it's all going to be about what's put out. I mean, I think some of the, I just reading an article on Substack this morning. I think the author was Tyler West, a former Naval Special Forces operator, who went to a defense contracting conference, and he talks about how like these new AI software platforms that are being sold to the military and how they're supposed to be able to discern between like the spreading of disinformation versus correct information, and the AI models that, you know, what they pick up as disinformation or correct information, and what is all based on what you input into them. And if they're drawing from the larger pool of what is the internet, whatever people put into that pool is what's going to get drawn. So if misinformation is flooded onto the internet, then the AI model is only going to produce more misinformation, which is a danger. And another thing you remind me of is my early days in medical school, like being on rounds. I remember it was great, a great quote. One of the residents, I think it was on pediatrics or something, they asked, you know, she was explaining why she thought a certain treatment protocol for a patient was the right treatment protocol. And one of the attendings appropriately said, "What evidence are you basing this on?" And she said, "Well, I don't remember if it's Reader Digest level data or if this was actually Journal of American Pediatrics data. Anyway, I got the data from somewhere, and that's what I'm basing it on." But she makes a good point, right? And is that a lot of medical data, Reader's Digest and Newsweek and Time and, you know, MSNBC, and Fox News, they all produce data, and it's all out there on the internet. So as these AI systems are going to be sourcing this data, we're going to know whether it's Reader's Digest data or if it's from the National Academy of Sciences. And that is absolutely key. You want to know the level of fidelity of your data. And the other thing, it just reminds me of kind of one of the frustrations when I came out of medical school. There's two frustrations I think that every doctor experiences on a social from a social standpoint after becoming a doctor. One is watching medical melodramas on TV and how inaccurate they are. That's the first like realization. You're like, yeah, this does not. The amount of drama that occurs in a TV hospital in one episode probably would account for the amount of drama I saw in 10 years of my career. But the other thing is, like, you know, the constant sound bites you hear in the morning news or on the radio of, oh, doctors have now found that eating one Twinkie a day is actually beneficial for your health. What is this? And then you go look at that study, or you go look at that publication, and you know, it's like one data point from one research group that's in some corner of the United States, maybe not, maybe some corner of the world. And because it's such a catchy tagline, the media has taken it and spread it broadly, and then people look at it and they say, oh well, yeah, you know, one Twinkie is actually good for me, or, you know, the whole Diet Coke thing, you know, the headline, Diet Coke can cause cancer, you know, because, and then you go to look at this, it's like one study in like 10 mice showed that that there's, you know, like, it's like you want to tell people, yeah, they also found out that doing research on lab rats causes cancer. You know, as opposed to just the Diet Coke. So that's the first thing. So to your point, one study means nothing to a doctor. You know, one study usually is useless. You need, of course, multiple studies, preferably the double randomized clinical trials, et cetera. And then you need multiple of them. And basically all that's even giving you still is just one data point that you have to collect with multiple data points before you have any type of reliable information upon which you can build guidelines or confidently recommend treatment protocols. But yeah, this one piece of data, particularly if it's coming from Reader's Digest, usually useless.
So I want to unwind that a little bit. Because one of the things that I suggest to people when they're getting into a field that perhaps they didn't understand before is to find the key societies, find the guidelines, and read. Like completely, as a marketing person, and completely consume that so that you start to understand what's happening, where some of the comorbidities are. It gives you it's a short, well, maybe some people wouldn't call it short, but in my mind, it's a short, deep dive into kind of what's happening in that particular field, like atrial fibrillation or high blood pressure, hypertension, et cetera.
Yeah, I think we had tools for this. We had it starting around the mid to late 2000s. We started to, or the aughts, like 2010, 2011, 2012. There was a proliferation of software platforms that just like digested this information and gave it to you in a nice, readable, up to date as well. WebMD, right, was one of the original ones, and then UpToDate's another big one that's used heavily in hospitals.
Yes, I tend to find those aren't quite enough, generally speaking.
For sure.
So one of the things I want to go back to, because I find it really interesting, is this idea that, well, not idea, I think we could probably prove this if we studied it, that I'll say marketing people, the media, marketing, PR, kind of, we can throw all those people in a bucket for the moment, including myself, that there's a tendency to go and find the most outrageous, like you said, one Twinkie a day is good for you.
Yeah. For your health,
most outrageous thing, no matter whether the data makes any sense or not. And what I've also tended to see, and I'm curious if you've seen this, is if you, number one, no one cites the article. There's usually, it's very rare there's a link to the original data. So you have to go I have to go try to figure out, like, what was published in the last month? What could they possibly pull? And usually when I find the article, they've pulled they're so far away from kind of the main point of the study to begin with. And they found some like small piece that wasn't even an endpoint to pull out. And then the writer pulls it out and talks about it. But then someone else is in charge at these large media corporations of titling, right, to get engagement. So they A/B test certain titles. And if those aren't quite working, they'll go back the next day or in a couple of hours and tweak the titles. And so what happens is that there's this drift that happens. And so sometimes I will click on them because I'm like, that's absurd. I wonder how far away it is from what was actually studied. And I think there's I don't know how we fix that, but
disconnect. It's
wrong incentives, right? It's the wrong incentives,
Yeah.
right? You're incentivizing people for engagement and not for some kind of ethical behavior that they should be following, whether it's marketing and media people or other folks.
Yeah, I mean, I think you've kind of diagnosed the disease of mass media, right? Like everything, I don't want to say everything, but like you have to get attention, right? Like you have to get clicks. So the clickbaity sound bites are what are going to get the most clicks. And that, medicine, unfortunately, medicine is not immune to this. Medicine, there are medical sections or healthcare sections in every major newspaper. There are healthcare, obviously, websites, podcasts, influencers. And in order to get those clicks, in order to get those views, you've got to have the catchy term. And so is it going to be catchier to say, hey, listen, diet and exercise can actually increase your health span and your lifespan? Is that really going to get that many clicks? Or is saying something like eating a bucket of butter can actually improve your mental capacity? I mean, I'm going to be curious about the bucket of butter one. I'm going to click on it every time and be like, what? I love butter. Let me go see this.
Who said I can do that? I want to know how, why.
Yeah, and it's so funny because as a doctor, you get bombarded, but particularly by family members and friends, right? You get bombarded by this stuff. They'll send you something like, "Hey, did you see this article?" And of course, they probably didn't even read the whole article, or if they did, they just skimmed it. And then you go actually do the deeper dive into the science or to the medical, the physician that they quoted in the article, and realize that it's all, bogus.
It's interesting because I don't think there's a way to unwind the incentives. They're kind of baked into media at this point, except for some of those that hold themselves to a slightly higher standard. But a lot of it, the incentives are baked in incorrectly. And I think what was interesting about one of the things I thought about when you were talking about the, I don't know if it was value-based purchasing, but it was the group in Philly and it got hot and they were trying to manage, right? The patients in the best way to keep them out of the ER and urgent care, et cetera. And they bought them air conditioners. And the first thing I thought of is, what were the incentives that drove that behavior? Because if you can unwind it and figure out what those incentives were, That's a pretty, right? It's behavior, right? It's how do people behave? And people usually
Yeah.
behave in response to incentives of some sort, right? Their family will do better, they can buy a bigger house, they can, you know.
Yeah. Are we talking in that case, in that scenario, are we talking about the incentives of the patient or the incentives of the doctors to go buy the air conditioners?
The doctors, yeah, the incentives for
Yeah.
the physicians to understand that they had this kind of broader picture to manage, and therefore they were thinking more broadly, right, and more holistically about how to manage this patient as opposed to writing scripts and scheduling surgeries and running
Yeah.
tests.
Well, let's. I'm going to try to be a little bit rabbinical about it, and give everybody the benefit of the doubt. So humans are creatures of incentives. We generally know from evolutionary psychology what are the incentives that drive human beings, and particularly the economics of what drive human beings. It's sex, money, power, kind of like some of the top three. Sex,
Mm-hmm.
money, power, influence. Respect of your peers, things like that. But really, sex, money, power. And so, if you look at, and I will say this, I will give being rabbinical, I'll give ChenMed the benefit of the doubt. They're also a religious based medical
Mm-hmm.
organization, and so
Mm-hmm.
I assume that there is a religious incentive as well for them to do right by their patients, in addition
Mm-hmm.
to the professional incentive to do right by their patients. And we all of us doctors, we do ascribe to the Hippocratic Oath, and I think most of us take it seriously.
Mm-hmm.
But then there's also the financial incentive, right? So when I look at that scenario, and I don't want to imply anything, I don't know all the data points to it. I just heard about it, on a podcast. But
Mm-hmm.
as I understand it, the way it works, because they're in an accountable care organization, accountable meaning they are
Mm-hmm.
held accountable financially, I believe, if their patients end up in the hospital. So if their patients end up in the hospital, that's very expensive. And if their patients end up in the hospital, they are going to become responsible for a portion of that charge, or they'll lose part of their um, bundled payments to paying for that hospital admission. So it essentially amounts to a loss of money for the practice if their patients end up in the hospital. And I can assure you right now, having worked in hospitals for the last 15 years of my life, I can assure you right now that that hospital stay, whether it's 1 day or 5 days, is going to be substantially more expensive than a carrier swamp AC that you can put in somebody's window. It'll probably be exponentially more expensive, right? So it just makes financial sense to buy them the AC, prevent heat stroke, heat exhaustion, and prevent that hospital admission. So I think there's a financial incentive. There's a career, psychological incentive. You're a professional incentive. Being a doctor, you are trained and you ascribe to a Hippocratic oath that
Mm-hmm.
makes that the right thing to do. And then I think in the case of ChenMed, there's a Judeo-Christian ethos that they ascribe to
Mm-hmm.
that also has them want, there's an incentive for them to do best by mankind, their fellow man. So
Mm-hmm.
I think they're doing the right thing. And I kind of look, in a weird way, after hearing that story, I was so inspired about that. I try to look for like just little ways that I could do things like that, like going down to my local bagel shop and just saying, hey, don't throw out the bagels at the end of the day. Let me just take them and hand them out to homeless people, right? And like
Mm-hmm.
hopefully, get them fed. And then I realized, 50% of the homeless people in my neighborhood are overweight. And then I was like, well, this doesn't make sense. So maybe I should be giving them bagels.
Yeah.
Right.
I don't mean I don't mean to laugh, but I think that there's a lot in there,
Right.
and I think I'll back up from the bagel story here for a minute, and I think the idea of lining up economic incentives with, right, we've known, right, whether it's fee for service, value based care, or something, right, there's the need to get the clinical part right, practice good medicine, help people get well, et cetera, or prevent them from getting sick, right, one or the other. So there's that kind of clinical piece of it, and then there's an economic piece, right, whether it's how the employers decide what's covered and what's not covered, or how to reimburse, or in which settings to reimburse something. So there's always been that kind of clinical economic piece. I think what's interesting is when you switch the when you switch the economic piece to caring more to preventing certain things from happening, it switches the actions and what people do, right? As opposed to paying people for them happy. So, I mean, we know this, right? So if a surgeon does a surgery, they get paid X, and the facility in which they do it gets paid Y, right? But they
Sure.
don't, surgeons don't get paid, X if they prevent a surgery. And the facility does not get paid Y if they prevent a surgery. So the
Correct.
incentives they're different.
Yeah.
They're different.
And so, like, if you look at, I'm reminded of a book that somebody in my life once forced me to read. It was called Eat, Pray, Love. I think it became a movie at some point, right? And I'm reminded of this part of the book. There's one thing that I don't remember much of the book, but I do remember one part. I think she was in Italy or something, and she's having a conversation with this Italian bloke that she met there. And he says something like, every city in Italy can be described by a name, by one word. And like Rome, the word is sex. I don't know. Florence, the word is art. Pisa, the word is leaning building, whatever, but they're like each city can be defined by a word or two words. And I'm reminded, when I think of healthcare, if I at least in the early 2000s, in the last, let's say 15 years or so, if I had to use one word to describe healthcare, the word would be volume. Surgeons, during in my surgical training, we're rated on our volume, much in the same way that a pilot is rated on his flight hours, right? How many surgeries have you done? Those surgeons who can amass the most amount of surgeries in their respective field are going to be regarded as the best because they've done 10,000 gallbladders, 10,000 thyroids, whatever the case may be, right? These astronomical numbers. That's how you're rated. And to get those numbers, you need volume. You need patients coming. You can't turn away somebody's who's got a minor case of cholecystitis, which might actually resolve itself and it may never reappear again, or there's a 20% likelihood that it will reappear in the next 10 years. You can't turn them away and have them go home because that's a gallbladder that you could take out and just up your numbers. So there's that volume. And then on the maybe not on the opposite hand, but on the same hand flipped over is the volume of the money, right? Like the hospitals are trying to keep that throughput going, keep that volume up, because each patient, as sadly as this sounds or is, represents a revenue source. And so you want to get that volume in so that you can get the payment from those patients. And so there were all these, as I was going through training, and being in the military, spending time at MGH, it was like the same, whether I was at MGH or whether I was at Walter Reed, it was like, we need patient throughput. We need it so our doctors can get skilled. We need it so that we have these volume numbers for our quality metrics to show that we've done X number of cases. Therefore, we're proficient at it. And then we need it for the money, money aspect. And so the word was volume. Get the volume through. The transition now, or what CMS is trying to do, is get away from that volume and that fee for service and that swiping, that need to swipe the credit card. Go away from volume to value. Go away from volume to better outcome. Now they want to transition the word for my entire career in medicine has been volume. They want to make the word either value or better outcome. Maybe two words: better outcome, value or outcomes. And so to make that happen, that you're right, the incentives are going to have to be realigned, and there's going to have to be an almost 180-degree shift in the mentality of how patients are taken care of, how systems are set up, because right now they're set up for volume and fee for service. And an EHR, in many cases, an EHR is nothing more than a very fancy cash register. And when they teach us doctors how to write our notes in there, they teach us all the buttons we need to push to make sure that we get paid or the hospital gets paid. Even I was in the military. Yeah, we're not even working on payments. We still had to click those buttons.
Got it. Yeah, so solving healthcare here today.
Gargantuan problem.
A gargantuan problem. But I think, when you're talking about the Chen, I don't know if it's a Chen group, but that group in Philly, and buying air conditioners that you heard about on the podcast, I just thought incentives. And I'll say from the Medtech side of things, I've seen there's nothing like setting up an incentive program for salespeople, right? And there's a new one every year, and it gets tweaked usually every quarter. There's nothing like setting it up and launching it and watching what actually happens. And I've had input into those. I've never developed the entire thing myself, right? I came up through engineering and product management and marketing. Um, but I've definitely seen times where they didn't reward, you see very quickly where people are going to spend their time based on where they've realized, hey, you were rewarding me to do this new thing, but that new thing is going to take 10 times more time than doing this thing. So I'd rather do more of this and less of that, because the volumes and the numbers, right? If I can get 10 of these and it takes me a fifth of the time that it takes me to get 10 of these, then, or sell 10 of these and 10 of it, right? Then they're going to do the one that takes less time. They will always be efficient with their time, because what I've seen, that salespeople are driven, right? They're incentivized. Let's put it this way. They're incentivized. I want to speak to their behavior as a group.
Yeah.
They're incentivized to drive sales generally, right? And to drive volumes.
Sure.
And there are other pieces that are in that part of that incentive program. I mean, it's not all just selling stuff in dollars, but a big piece of it is. And I think in listening to you talk, it certainly seems that perhaps CMS set up the wrong incentive program.
Yeah. I mean, I think they set up the incentive program based on what they could make happen. Like I said,
Right.
In order to do a value-based system, you need to have a global visibility of your patient, because, you can't try to link up the incentive. Look at it this way. Now that we have a little bit greater visibility of our patients, and we're collecting data in the interwebs, and we're able to source this data and give it back to physicians. Think about it this way. If I can now get data on what my patient's blood sugar level is in real time, and I get updates on my computer from their little widget that's on their phone or whatever the case may be, I now will know when my patient is overeating or is not eating the right things, or is indulging a little bit too much, and then I can intervene. I mean, I guess in theory, I could intervene right there in real time if I wanted to. So let's say that rather than doctors being incentivized for providing care and swiping that credit card on the EMR and clicking all the buttons for like, yes, I did this, yes, I did this, yes, I did this, to the 40 things that you supposedly did in your 30-minute patient visit, which are now going to give you your income. Let's say we now said we're going to pay you for every point of BMI reduction below obesity level for your patient population. Something like that. I mean, that's an oversimplistic way of doing it, but let's just say we started to do something like that. Or we're going to pay you for every point of reduction in blood pressure that you score for your patients. Or we're going to pay you for miles that your patients can walk now, or flights of stairs that your patients can walk to measure their cardiovascular health. If we started incentivizing those things, and then we now have the ability to garner that data, to obtain that data, how when are our patients elevating their heart rate, i.e., when are they doing exercise? What's their blood sugar levels? When are they overeating? What's their weight? What's their BMI? What's their body composition? We can get that data. We can source it. We can immediately upload it to the web, and the doctors can be given that data, and so can the payers. And the payers can see very quickly whose patients are getting better and whose patients aren't. And so armed with that data, I think that was the linchpin that was missing, that CMMI and CMS hasn't had until now, because you need that 360-degree visibility in order to be able to follow the appropriate incentives. And the appropriate incentives are health, not the amount of care delivered, not the amount of swipes or the amount of things you did in the EMR. It's what are the metrics of the health metrics of each individual patient.
Right. And I just want to be clear. I'm not trying to take out or poke CMS or anything like that. We all do the best we can at the time at which, and the time in which we exist. Right. So we're kind of turning it over, but I'm just trying to I don't want to say disarticulate it, right, but disaggregate it to try to figure out what might actually move the needle, because, we had some experiments a few decades past, HMOs, this other stuff that, some work better than others.
I mean, it's the same. I guess it's analogous, like education, right? Like the teaching of our children. We have this idea. I'm born and raised Californian. And we have this idea, this was very prominent in California, that like we're going to start paying teachers. I think this was during the W.H. Bush administration. We're going to start paying teachers based on the performance of their students.
Yeah.
Is it reasonable to expect a teacher who has a child with them, not even just one child, they have 30 children with them for 4 to 6 hours a day, depending on the grade. But then the remainder of that child's life is spent outside of the classroom, of which the teacher has zero visibility. And they can be doing anything. They could be, playing video games all day or reading misinformation on the internet. And then we're going to make that singular teacher responsible for the intelligence outcome of that child. That you can't do unless that teacher has 360-degree visibility on what that child is doing all day and the ability to intervene at any given moment. You can't really make it's not reasonable to make that teacher responsible for that child's cognitive abilities. In the same way, it's not reasonable to try to pay doctors on the outcome of their patients if we don't have the ability to see what they're doing at all times and the ability to kind of intervene at all times.
Yeah.
Right? Put down the corn dog, put down the chili dog.
Yeah, the tools, right? The tools, you said, the tools that you need to be able to do that kind of in an efficient and effective way.
To your point, so CMS has done the best they could with the tools that they had. But now, we're on this cusp of this new healthcare revolution where, Amazon is now investing heavily in healthcare. I mean, they're saying that healthcare startups are going to be the next FANG companies, in the .com revolution. The Netflix, the Facebooks, the Teslas are all look at the data. They're all struggling right now, and so some have proposed that the next wave of major innovation and market activity will be in the healthcare space, which I'm sure will be. This is a good news for all your listeners. I promise, Maureen, that there'd be something good that I say.
I think that's great. And I mean, I've seen that, there's been a sea change since I started, in MedTech, and a lot of amazing inventions and evolutions in care and all of this. And we, the goal is, it's the continuous improvement, right? We start where we are, and can 1% better? Can we 1% better every day so that we're 365% better at the end of the year? So, and the same holds true for reimbursement or marketing, or that it's a non-vegetarian phrase of the eating the elephant one bite at a time. I don't know what the vegan version of that would be.
Yeah, I mean, I'll say working with Pearl Health, as being that it's a startup, I've kind of got an insider's view of rapid innovation, rapid iteration. So I'll tell this for anybody else in the military who's going to be getting out, particularly the special forces guys who are used to very rapid, dynamic and rapidly evolving spaces. Startups, what has surprised me is how fast they work. Basically one person says, we should, before they can even get the sentence out, you have 10 people who are already doing that thing, and it's done before they're even finished the sentence. It's crazy. It's crazy how fast they work. I remember, I could ask when I, in the military, I could ask like, hey, we need more toilet paper. It could take 3 months for us to get more toilet paper rolls at our building. But like at a startup, you say, I want this, X software update made to this platform. And before you're done with the sentence, somebody's already done it. And they're like, hey, will this work? It's amazing. It's completely, that's credit to the engineers and data scientists at Pearl Health, but it's also, I think I've heard that's just the way startups work. They're just fast and very innovative. And so that iteration process happens very quickly. Whereas for other organizations, particularly government organizations, it just takes a long time. That iteration cycle is very slow.
Yeah, understood. Yeah, startups are amazing that way. And that kind of, the people have that attitude and that risk. How should I say it? They don't have an aversion to risk as much. So, for example, I worked in the San Francisco Bay Area for 8 years, and it's just a very specific ecosystem of beliefs around. There are lots and lots of, right? Lots and lots of MedTech startup, MedTech, health tech, digital health, et cetera. And so the expectation was never, I want to turn this in, take this job and turn it into a 20-year career. It's, I want to grow this fast, do the best thing, talk to all the right people, make this something, and then get it sold. to one of the large billion-dollar companies, generally, some IPO, that's pretty rare, and then go on and do the next thing. And I think that makes that startup. So I love startups.
Yeah.
There
Yeah.
is that energy and that dynamism, and not I'm buried under 10 tons of bureaucracy, and so I can't move
Yeah.
without
And
alerting 10 people that I'm going to take a step to the left. So
for sure. And I think for any of the listeners, we talked about MedTechVets. So for any of the military people who are looking to, build their second life, repot themselves as in the startup world, I will issue both the warning as well as the invitation. To say that, you go to the startup world, like things are going to move very, very quickly. Just be prepared to be the person that the minute somebody says, I need, that you're on fire building whatever it is that needs to be built. So things move very quickly, and you have to be prepared to harness your energy and move at least with the pace of the startup, if not try to be a little bit faster, which I think for a lot of military people, particularly your special operators and special warfare folks, I think that's what excites them. And that I think they tend to flow very nicely into that type of environment. On the other hand, you go to a startup, you're going to work above your pay grade, below your pay grade, across your pay grade. Like, you're going to be expected to do all levels of work. And so, that's one of the, you can't come in with any type of ego. Like, you have to be prepared to do just about anything and everything to complete mission. And so I think that's the corollary with being in the military, is that it's mission above all else, mission accomplishment, mission completion, and mission accomplishment, mission completion quickly. Like, get it done and get it done fast, which has been one of the more exciting aspects for me working with a startup to making that transition. It's just been, I've really never seen anything else quite like it.
That is great information, and a great kind of call out to people about what it is, and what makes it really fun, and what also makes it very challenging, right? Yeah. So you need to be ready to kind of drink from a fire hose and run.
Oh, for sure. Yeah. While you're on fire yourself. Yeah.
There you go.
Yeah.
There you go. All right. Or at least your attitude and focus is on fire.
Yeah, exactly.
So we've covered a lot of ground, from population health and tools and 360-degree holistic view. One last kind of serious question. So this 360-degree kind of holistic view, and being able to manage or intervene or provide education, whatever the appropriate response is, to try to modify behavior to achieve, so the patient's healthier at the end of the day, to achieve health at the end of the day. A lot of that's going to take place outside, as you said, kind of outside of the facilities or the environments, or outside of seeing the physician. The MedTech conference, I think it was Alyssa Lynch who said that 70% of healthcare takes place outside of, hospitals and clinical environments and that. And with that in mind, as we think about the home and needing some of that data, do you have any sense for what we should be thinking about, or how that might happen? Or I think particularly the home is a really interesting one that a lot of people are talking about right now, right? CMS had their hospital to home waiver during the pandemic.
Yeah.
And early small studies, early data appear to show that ER readmits, ER visits are reduced, patients are happier, this kind of thing, recovering in their home in a certain group of appropriate situations where that, not ICU patients.
Yeah, no, I remember, during my surgical training, we would try to get patients out of the hospital as quickly as we could. And I remember there being, I don't remember the exact data, but we would always quote data when we were sending patients home that, for every day they're in the hospital, there's an 30% increase in the risk of a hospital-based complication. Mm-hmm. Right. Mm-hmm. So for whatever reason, patients just do better when they're in their own home. on that same point, when we discharge patients, to make sure that they don't get readmitted, I remember we'd have to ask a lot of patients just questions that I never thought I would ask as a doctor. Like, do you have a lot of cords in your house? Do you have a lot of rugs? Do you have a lot of stairs? Right? Because trip hazards. And do you have an AC? Do you have climate control? Do you have pets? Do you have appropriate pest control in your building or your home to make sure that there's not infestations? So yeah, I mean, all of that stuff kind of incorporates, right? So like to your point, when you're asking like, how can we collect this data? What data should we be collecting on our patients? There's all these environmental factors, right? Like I'd love to know my Nest temperature control thing here tells me what the temperature in my house constantly. It's on my phone. I can look on my phone at all times, and I can look right there, and it's a constant 73 degrees, just like I like it, right? In theory, doctors could get why shouldn't doctors be able to get that information for their patients? What is the temperature in their home, particularly during a massive heat wave, or during a cold, like snowpocalypse, which I experienced in I think 2015 in Massachusetts. So there's things like that, the environmental data. And you can imagine how deep you can go in that, right? Like what airborne toxins are they being exposed to? What other elements in their home, what's the level of asbestos, or they even have like meters that test for like the bacteria in the air. You can get really deep on that stuff. So just know like all the environmental hazards are in a person's living space. And then also just their own personal health factors, right? I mean, I have a scale here that measures both my weight, my BMI, and my fat percentage that I get on fairly reluctantly once a month or so. But imagine if that could be on my watch, or I could just get on it once a day, and then it goes directly to my doctor. My doctor will know immediately, hey, you're gaining weight. What's going on? Did you drink too much water? Is this water weight gain, or have you gone on a bender lately? That kind of stuff. So, yeah. And just, the difficult part for doctors in the future is going to be collating through all that data, right? You're going to need systems that really access and pull out the actionable items out of that data, rather than just flooding us with so much data that we just get warning fatigue or alert fatigue, because you're just constantly getting these alerts. But I mean, I think there's definitely some room for innovation in that sphere.
Yeah, I'm excited for that. I think there are tremendous opportunities to help improve health along, right, value-based health, or whatever, however that kind of morphs, and the incentives morph in that regard relative to CMMI and what they're doing, and other folks are trying out, and all the things that are going on in the home to help understand better kind of what's happening outside the walls of what we call healthcare per se, or the facilities per se, right? So
right.
And I love your call out to veterans and also to MedTech companies as to my personal experience, not having been in the military, but having reviewed lots and lots of resumes and hired people who've come out of the military, that they tend, very rigorous. They listen, things get done. You don't have to ask them twice. And I think I've seen sometimes trying to pull people in from not less rigorous environments, or not non-regulated environments, that there's some umbrage taken at, why do we have to have our XYZ marketing reviewed by somebody else? Or why does regulatory get to weigh in? Or why does legal need to look at it? And that holds true in no matter where you are, whether it's medicine or med tech or digital health or engineering, marketing, et cetera, right? There are these rules from multiple different regulatory bodies about that govern what we do, with the goal of making us all safer.
Yeah,
so,
for sure. And I've been impressed. The people in MedTech that I've met through MedTechVets, I will say this, I've been impressed by them, just absolutely across the board. Super impressed. And then there's just also the other thing I don't want to forget is just like, when I wrote my personal statement to medical school, the tagline for that personal statement was, I ultimately, because I had a lot of different opportunities of things I was thinking about doing career-wise, and the line that resonated the most and that I wanted to make sure that was the message that the admissions committee received was that I'd ultimately decided to go into medicine because I wanted to devote myself to a life that was unambiguously good. And medicine, healthcare felt like that was the arena where I could do that. I felt so much like if I were to go become a lawyer or if I was going to become a businessman, there would be a point like in, that Grisham book, Rainmaker, I think it was, where like ultimately you have to question your own morality if you're going to continue to be successful in this. And I felt like in medicine, I didn't have to do that. I felt like I could keep my morality intact and still be successful. And so as I interact with the MedTech Vets group, I hear a lot of them say that. I went into the military because serving in the military was the best way I could give back to humanity at that time when I joined. And now I'm leaving the military and I want to go into something that will allow me to maintain that commitment to the overall benefit of humanity. And so, to all the medtech companies out there, the biotech companies that have a mission to serve humanity, who have a mission, who want to do good for society, I think you will find the right cultural matches in our service veterans and our military members.
Great. So on that, a couple of quick questions.
Yep.
If you get to wave your magic wand and you get to travel anywhere tomorrow free of charge, and you still keep all your jobs and all your friends and everything else you want, right? Of course. Where are you going and why?
Oh, wow. Holy smokes. Gosh, it's a hard question. I don't know if this is a place, but it's the first one that comes to mind, probably just because of a recent interaction that I had. I've recently been desiring to take a trip to Patagonia. I've been to Argentina once before in my life. That's kind of the closest to that region that I've ever been. I think I just read an article recently about it and just kind of like how pleasant the communities are down there and how warm and welcoming they are. And also just like a massive curiosity to go see it and experience it. So I don't know that that's the right answer. Maybe if I gave it some more thought, but that's the first one that comes to mind.
Your answer is whatever your answer is, and that's the right answer.
That's it.
For you from that standpoint. If you could give, I know you've already talked about kind of MedTech vets and that, and do you get advice to anyone who is going into med school today or is thinking about medicine, right? Where there's sea change happening at the moment. What advice would you give them?
I think the advice I would probably, there's all the standard advice that you give, like just be prepared. It's a long haul. Medical training, it takes a long time. It takes a major toll. Depending on what part, field of medicine you go into, whether you go into surgery or, go into dermatology or emergency medicine or ophthalmology or whatever the case may be, there are periods of it that are like a monastic lifestyle. You have to devote everything about yourself to that field, to medicine, in many cases to the detriment to those around you. So be prepared to be 100% committed and devoted to that profession, at least at times. And then the other thing I would just kind of caution or have them think about is that medicine, and I'll just say healthcare in general, has become such a monolithic entity in the United States and around the world, but particularly in the United States, that as a physician, I think physicians are becoming increasingly smaller cogs in that larger machine. And so be prepared to, recognize what you are in that larger field, that larger arena, and make sure that you're okay with your place in that field. As opposed to if you want to be a founder. I know that, amongst Gen Zers, I think I read somewhere recently that most of them say the most common job cited for their future is like entrepreneur or founder. So if you have the desire to be an entrepreneur or founder and like head your own organization, I think increasingly doctors are not leading healthcare organizations. They're increasingly being led by allied health professionals or business folks. And so just kind of keep that in mind to make sure you align your values and desires up with what you're actually entering into.
That's great advice. Anything I didn't ask you were hoping I would ask?
If you were to ask me a question, Dr. Muñoz, if you could implement one healthcare strategy to ensure the better outcome of your patients, what would that healthcare strategy be today? Aside from healthy diet and exercise, or aside from, like a healthier, health conscious diet and exercise, what I would say is what I'm very excited about. And I've actually written an article, but I haven't published it yet. And I'm kind of debating on whether or not to publish it because it's a little bit of tongue in cheek. But I would probably be prescribing the GLP-1 inhibitors to all of my patients, the Ozempics and the Manjaros and the Wegovias, because if you look at what kills Americans, it's lifestyle, it's diseases of lifestyle. And a lot of them are metabolic syndrome, overeating. And I want people to imagine a world where we gave people these GLP-1 inhibitors and it reduced their appetite by like 70%. So they're eating 70% less food. Think of all the problems we could solve in the world. There'd be a healthier population, assuming that they ate less and they ate healthy foods when they did eat. You would have less waste because we'd be producing less food. So the demand for food would go down, which would then hopefully include a lesser demand of meats, which would then have the ancillary benefit of reducing methane gas emissions in the form of our meat producers. And so you'd have reduced global warming. So in this article that I'm still flirting with that I haven't published yet, I'm seeing ways and factors that by prescribing GLP-1 inhibitors, which basically just reduce your appetite to almost nothing, how they can save the planet if you follow that connection. So I haven't explored it enough. I can't give medical advice yet on it, but that's probably what I'd be doing.
You think big, which is great. And I think, those are, no, I hear disfluencies and I'm saying, those are the kinds of ideas we need, right? Those are the kinds of things, the big ideas that can have a substantial impact. I mean, I think we've been incrementalizing for a while, and there have been great technologies and great steps forward, et cetera. And I don't mean to minimize any of those, but to get where we need to go from where we are today, we need to do some big things to think across sectors like that.
I think, thinking big and acting in accordance with that. So thinking big and acting big are the big rules, which once again, going back to like the startup culture, the at Pearl Health, the cultural values, the number one cultural value that they have, and you can find this on their website, is anything is possible. And you should think and act accordingly. Right. And so one other thing that I just really love about the startup culture, to your point.
That's great. Yeah. That is great. I love those ideas. And I think we need, I know we need to have more ideas like those that kind of come out of medicine and think holistically. Now you're not just talking holistically about the patient, you're talking holistically about,
society, civilizations as a whole. Yeah, for sure. Mm-hmm. Yeah, absolutely. And these tools as they come out, particularly tools that your listeners are inventing and bringing to market, those are the tools that are going to give us those abilities. Like I said, I mean, we all know what needs to happen. I think we know the targets. We know the things that need to be addressed. I think just historically, it's just been a lack of tools to take those measures, to be able to be effective in tackling those targets and hitting those targets. It's just been a lack of the appropriate tools. And so now technology, it allows us to move in leaps and bounds, and it, I don't know if it's the right word, but it exponentializes our abilities, right? It amasses our abilities. It makes us bigger than we really are, and able to do things quicker, faster, stronger than we did things in the past. And that's what you need in order to attack and tackle these bigger problems. So I do want to send out that credit to all of your listeners who are out there, fighting that battle. I think the world will be a better place for the things that they do.
Absolutely.
I would just, I did want to, as one last disclaimer, I did want to apologize to your listeners because I think I probably am not the standard. I've listened to a couple of your podcasts. I'm not the standard guest that you normally get. And I just hope that I covered all of the information, provided valuable information. And if anybody wants bad medical advice, I can also deliver that too, in addition to podcasting material, free of charge.
You don't have to say that. No, it's, I think it was great. We talked about a lot. There are 1,000 things we could talk about. For sure. And it was fascinating for me to talk and think through and hear you talk about it and really listen to it and listen to what you're saying. So I'm sure they'll enjoy it as well.
Well, thank you. I definitely enjoyed meeting a fellow Dookie, and this was wonderful. And I'll just give out. So if anybody does want to contact me, because I have a pretty small social media presence, but if anybody wants to reach out to me and further talk about anything else that you and I covered, my email address is, so JB Muñoz is my name, but my email address is just all of that written out. So it'd be Juliet Bravo Muñoz. So JuletBravoMunoz, Juliet Bravo Muñoz @gmail.com.
Now we really know that you were in the military.
Yeah.
Or a pilot in a former life or something like that.
That's right.
Thank you for joining me today for this. I very, very much appreciate it. And that's it for Message Engineer Show. And we'll see you next time.